Right. Welcome, everybody. Um, Exciting to see. It's like watching the numbers keep on going up. We have over 250 people registered today. So thanks for joining on behalf of the Regional Geriatric Program Central GERAS, McMaster, and Hamilton Health Sciences. Welcome. For the next half an hour, we're going to talk about frailty. What the heck is it? Now, if that title didn't interest you into joining, I don't know what else will. And so we're going to hear about why it's important to assess frailty for a more complete, holistic approach to older individuals and a more tailored care plan. My name is Dr. Alexandra Papaiwanu. I am the chair of the Regional Geriatric Program Central, professor at McMaster, and the executive director of the GERAS Center for Aging Research here at Hamilton Health Sciences. From the housekeeping perspective, we're meeting in Zoom. As guests, your cameras and your phones are muted. We invite you to put in questions through chat. And as well as doing the survey at the end. I'm really delighted to introduce Dr. Courtney Kennedy, who is a clinical scientist, associate clinical scientist with the GERAS Center. She's also a coordinator with the hospital to home program here at Hamilton Health Sciences and an assistant part-time member of the Division of Geriatric Medicine. Thanks very much and welcome, Courtney.
Thank you, Alex. I'm sorry, I'm just going to share my screen. Give me 1 minute. Thanks for the nice introduction. Okay, we'll get down to it. I'm going to try to do this in 25 minutes. So frailty, what the heck is it? The first question actually I have for you is, do you think you could tell if someone is frail? And probably you have some thoughts on that, but if so, how would you know? Sorry, I'm just trying to advance here. Okay, so if you look at these pictures, could you tell from looking at these who was frail? There's different levels here. What are some of the ways that you might tell? The British media, when the Queen was alive, definitely had some thoughts on frailty. There's a lot of headlines talking about that, like she's fragile and weary, Queen to cut back on commitments, she's become very frail, she's lost a lot of weight, she's become too frail to walk her beloved corgis. And apparently she's admitted, as you can see, I can't move. So what they were the media was engaging in is what we might call like the frailty eyeball test. And there's some things that kind of stand out. They were, commenting that she was fragile, weak, looked more weary, clear weight loss, that she's had loss of mobility and change in daily routines, not walking her corgis. She definitely reduced some of her activities, which was evident. And her appearance maybe that she's appeared more kyphotic or stooped and had some bruising that was obvious. However, what we're going to talk a little bit more today is why assessment matters. And there's actually been research talking about, is the eyeball test actually valid? Because it does happen in clinical settings as well. And what it really tells us is that there is not good agreement between eyeball ratings and standardized frailty tools. I mean, there's some, but it's not an excellent agreement. And it doesn't necessarily get to the bottom of why the person might be frail. So just if you think about, you wouldn't buy a used car without doing a proper diagnostic assessment. It's important to do that with frailty and to sort out what are the underlying contributors, and then of course assist with care planning. So why does frailty matter? So in Canada, frailty matters. I mean, this is just an infographic from the Canadian Frailty Network, and showing us that it's quite prevalent. It's a burden on our healthcare system. A lot of Canadians are frail, and as we know, everybody on this webinar today knows about our rapidly aging society. So it's quite a problem. I'd just like to talk a little bit about how it matters in hospitals and at the individual level. So Lancet recently did a really nice meta-analysis looking at outcomes of frailty for frail patients. Lots of countries around the world mainly looked at general medicine cohorts, and they adjusted for age, sex, and comorbidity. So they took that out of the equation. And what they found is that for those who are moderate or severe versus no or mild frailty, there's a much greater increase of all these events. So increased mortality, lengths of stay greater than 8 days, discharge to a location other than home. So if you look at it another way, that's about 100 to 200% increase in risk if you're frail. Why frailty matters at home. Of course, I mean, so this is just a nice little graphic that goes through some of the things. So if you are in the pre-frail or vulnerable category, you might have more difficulty getting around outside, going places, walking longer distances. If you're in a mild frailty category, so you're getting a little bit frailer, is you might start having issues with housework, getting out to do your grocery shopping, maybe taking medicines. And as you're going more moderate, maybe then you're adding, you might need help with showering, possibly getting dressed, and more severe levels of frailty, you're going to need help with all of those things. So I just put this on because, and we'll talk a little bit about this later, but key skills, I think, for independence that are hugely impacted by frailty and things that we can target to improve. So of course, walking, so having adequate gait speed to do things. If you're less than 0.8 meters per second, you're at increased risk of several things. Transferring, of course, getting out of a chair, getting out of bed. Stair climbing is more difficult and not always necessary if you're in an apartment, but it makes it more difficult if you're trying to get out of your house or get out in the community. And medication taking, hugely impacted by frailty. So I'm just going to do a brief section on what is frailty. What the heck is frailty? Because we could talk a lot about that, but in the interest of time, I'm going to try to keep it pretty short. But so frailty is a clinically recognized state of increased vulnerability resulting from aging-associated decline in reserve and function across multiple physiological systems, such that the ability to cope with everyday or acute stressors is compromised. Yeah, that's a pretty, it's a good definition, but it's a pretty complicated definition. So really what that is saying is that with frailty, the gas tank is starting to get empty. You can see, you know, you get with the more severe, you're getting near that critical empty line. It's also an important concept that it's not just one disease, it's multiple physiological systems. And it's an inability to bounce back. Another really nice sort of way of thinking about frailty is that it's a variability in health status and in the risk for adverse outcomes for people of the same age. So if you consider all of these ladies here are 92, I picked 92 because that lady on the left, her name is Olga, and she was a Masters champion in long jump. So she's obviously exceedingly fit. Genetically, she's obviously got good genes. But just to illustrate that they're all the same age and they're varying degrees of frailty. So it's not synonymous with age necessarily, although it's exceedingly associated with age. So frailty is also an accelerated decline from normal aging process. And we're not going to get into that, but there's a number of accelerators that leads to that frailty and loss of reserve. I will just like to talk a little bit about what it's associated with. Across the lifespan, women do tend to have higher levels of frailty, a lower level of education, a lower socioeconomic background is associated with frailty, polypharmacy, sarcopenia, which is a loss of muscle mass and strength. That is often a key component of sort of physical frailty, and multimorbidity, so having multiple chronic conditions. Also, cognitive impairment. So there's actually a group in 2013 that termed it when you have both cognitive impairment and some physical frailty, they call it cognitive frailty. And definitely loneliness and isolation is associated with frailty, and it's really bi-directional relationship. In this graph, just quickly, just is frailty, then what happens is there's often a disproportionate response to minor stressors, definitely in the more severe stages. So, and if you look at the green line, so individuals who are more robust and something happens to them, they have a UTI or they have a minor surgery or a flu, they have a little decline, but they can bounce back. If, especially as you're getting into more severe stages of frailty, if this happens, they're going below that line and into the independence and then really having a difficult time to bounce back to get back into their daily lives. Also, I just want to point out again that frailty is a dynamic condition that we can improve. So we're going to talk about that. So how can we assess frailty? There are a number of, well, there's a couple of not competing, but complementary approaches that really view, the one is physical frailty. So it's quite famous, the Fried frailty phenotype, which looks at preset criteria. So it's a measure of weight loss, exhaustion, gait speed, grip strength, using a dynamometer, and asking about questions about energy, using standardized scale, actually. And then you're categorized into a robust, pre-frail, or frail group. So it's sort of trichotomous way of looking at frailty. Dr. Ken Rockwood, who our group has worked with a lot, really a proponent of multidimensional frailty. Most people are probably familiar with this, the clinical frailty scale. So it's a 9-level scale, it's pictorial, and it's not just picking frailty categories, obviously based on the pictures. It's really meant to be a summary of after a clinical encounter and to incorporate that information. Also, the Dr. Rockwood has come up with the frailty index concept. I won't get too much into that today, but it's often done in research and in big electronic databases. And it's that thought that frailty is really on a continuum. And it's a lot of different factors that go into it. Just switching now to something that's near to my heart is the Fit Frailty app. It's a project that we've been working on for many years. And it's really combining those different assessment approaches I just went through sort of into one easy to use tool. We've gotten it onto the App Store. We've been validating and did some tweaks. And I think the final version really is going to be back on February 8th, if you want to download that and check it out. And a huge team has been involved in developing and validating that. So just in a nutshell, our app it's really meant to be a easy to use point of care tool. It includes short instructional videos, calculators, automated functions, and meant to be, if you're trained that a health professional or a research assistant could actually administer this. So it doesn't need to be a geriatrician. And there's 4 major categories. So we do a cognitive screen. There's some self-report questions. There's performance measures. And we also include, so it's the frailty index approach of looking at how many comorbidities somebody has, because the more that you have, the more likely you are obviously to be frail. So here's just a video. I hope this works. Just looking at some of the instructional videos that go along with it.
The frailty assessment includes interactive cognitive screens and optional physical performance measures, including gait speed, balance, chair stands, and grip strength. The full Fit Frailty assessment.
So the domains that we've included in our app are the comprehensive geriatric assessment domains, so very multidimensional approach. And ultimately, one of the cool things about it is that it does a results summary to help guide management. So to figure out what were those risk flags, what are the underlying contributors. And then it also does put it into an overall Fit Frailty score. So in this example, you can see the person is definitely into the frail zone 0.48. So in the last half here, I think about 13 minutes, I'm going to see in the next 10 minutes if we can talk about what can we do about frailty, and then just do a little case study. I'd first like to start just going through a little bit of the research evidence. also want to just point out that the stuff that I'm going to talk about today, really, it's probably aimed at that group who's vulnerable, mild, moderate, and maybe with some supports, that severe group. And this is our sort of community-based intervention target. So Dr. Papuano, I mean, the JERIS team are really leaders in community-based frailty rehabilitation, and now studying that on a large scale. So Dr. Papuano is the PI of 2 major CIHR trials. The one is FIT joints, which is in arthroplasty patients, looking to see if you give frailty rehab before that, do you have better outcomes after? And then the optimal trial, which is looking to test a model of frailty rehabilitation in just regular, community dwelling older adults with frailty or pre-frailty. And I just put this up to show, we don't just dream things up, but that there's lots of evidence that we've, looked at to see what is our model that we're testing. We're involved in a big meta-analysis a number of years. And what we've kind of, what's the 4 key components in the one approach, the Cadillac approach is testing in the intervention arm, just providing them with exercise 3 times a week, protein supplementation, having a really good medication review, and giving everybody vitamin D, if that's better than control. And actually in the one study, we're looking at exercise only as another arm. And since exercise is a really key component, that's the best evidence still for managing frailty, what should we be targeting? So the evidence does say that ideally it should be a dose of 180 minutes per week. It should include multi-components, so some aerobic activity, resistance and strength training. It should have a high challenge to balance in frail older adults who are at high risk for falling. So you can see that picture, that is the optimal study, doing some work at the bar there. And functional movements, so everyday activities should be incorporated. And the last point there is referring to sort of like dual tasking or multitask activities where we combine physical and cognitive tasks at the same time. So the segue that is into JERIS Dance, which this is another initiative, another program that's actually trying to be implemented across Canada, developed here at JERIS Center. Dr. Patricia Houston was instrumental in developing this during her postdoc. And there's been lots of uptake. It's actually available at the YMCA. And I just want to show you a quick video, just to, again, it can be done in seated and standing. They're standing here. But to show just some of these movements, the mind body that's being activated at the same time when you dance, and it's fun.
So we're going to step forward, and at the cha-cha-cha, we have the front and then back. Good. Big step, cha-cha-cha. Feel free to throw that cha-cha-cha in there with me.
So we've also, of course, we've also studied JERIS Dance to see the impacts that it has on older adults with pre-frailty or frailty or early mobility and cognitive impairments. So I'm just highlighting one study here where we actually found that JERIS Dance did improve chair stance. It improved balance, and individuals tend to walk faster at the end with improved timing and stability. So that was after participation it's a 3-month program, 14 weeks. So remember those key skills I was saying, can we target those to improve that? And we did find that we can. So I'd also now just want to move into, that's what some of the research says, but what are some of the practical strategies if you're dealing, with frail patients in your practice, for people in your lives, maybe even. So really the gold standard, as we know, is comprehensive geriatric assessment. Down the hallway, we have the Center for Healthy Aging here. There's also, St. Joe's also has a service, of course. This is very limited in the extent that we only have 168 geriatricians in Ontario. So it can be hard to access. So there are other, we love to refer to geriatrics, but if you can't get in, then we have to talk about some other strategies and other people who can be involved in comprehensive care plans for older adults. So I just want to say another target that I often think of too is targeting some of those common manifestations of frailty. And these are really the ones that, you know, Dr. Papillon would say anybody who's working in hospital systems that get our frail patients hospitalized again. And so delirium, frail older adults are at 2 to 3 times the risk of having delirium, often happens, as we know, after UTIs, at greater risk of recurrent falls, and medication-related problems, huge problems. So with severe polypharmacy and then figuring out a way to adhere and take medications, especially often when there's cognitive decline happening. So I just put up these infographics just as a reminder, don't have enough time to talk about all these, but that there's, you know, delirium prevention strategies, lots of different things on falls prevention, and also ways to improve medication adherence. So, and polypharmacy. So 2 easy ones. I mean, I love actually, I'm often amazed at how many people don't have blister packs. And that's, to me, seems like a really good way for them to actually track what they're taking. So it's often something that can be changed very easily. It could be delivered to the home in terms of reducing polypharmacy. I mean, even if you're not going to a geriatrician, even having a pharmacist review your medications can be really helpful. Activation and social connectedness. I'm sure everybody believes in the value of that. And there's lots of evidence to say, you know, mortality is highest for frail older adults who are also lonely or socially isolated. And just a couple easy things that I often think of is, I mean, it's hard to get frail folks sometimes out to programming, but I wish as a community we would have more of them available on our blocks. Having access to that, maybe a friendly caller or a visitor. VON has one, Red Cross has that service. Ensuring community mobility. Many older adults are no longer driving. Their social networks are diminishing. They often don't have people who can give them rides, and it's expensive to take taxis. So definitely improving. So having darts can be a way to get out there. Many individuals still also need somebody to go with them. So if they don't have that daughter or that son or favorite niece to take them, there are appointment services that we can refer them to. Food as medicine, also near and dear to my heart. I just believe so much in the value of providing older adults, at least with even one healthy meal a day. Meals on Wheels, amazing service. There's even been evidence to show that it actually does decrease feelings of loneliness. And it's a safety check. It's an eyes and ears if they're getting the hot meal delivery. Somebody's checking in on them on a daily basis. And if they aren't there, if they're not getting an answer, they will send a safety check from the police. Housing, income and housing insecurity, we could have a whole webinar on this, but just to say that's another area to target. Some of the areas that if you don't have adequate housing, if you're not maximizing entitlements, targeting that, so with a social services worker or a social worker to help assist with these things, very important. I threw this up. This is a recent Spectator article that my colleague brought to my attention. Joe Cox, if anybody has referred to the Hamilton Community Paramedics, an amazing program where they go out and we're working with frail seniors, especially with congestive heart failure and COPD. Joe I've worked with him actually, I've met him a couple of times, was instrumental in this program. And everybody is sorry to see him go in his retirement. Shout out to the hospital to home team who I've been privileged to work with and with our patients for the good work that this team is doing out in the community. Really, the goal is to develop coordinated care plans based on what's important to the patient and then follow that through with some wraparound medical and social supports. There are 6 coordinators and 5 Good Shepherd community health navigators. And you can see there in the blue box, that's just the eligibility criteria. So it is referral based, but it's the frequent flyers with chronic conditions. And then also over in our EDs, the CAT team, who's at the General and Jurabinski, really that timely and safe discharge, admission avoidance goal by using some comprehensive geriatric assessment. So it's of course under the community population health, under Kelly O'Halloran, some innovative programs. So finally, just a couple minutes left. I'm just going to do a case study just to bring some of those pieces together. So here is a fictional patient, Mrs. C, discharged from the emergency department after presenting with a fall. She's discharged home. Mrs. C is 75. She's a widower. She has some children, but they aren't able to support her because they don't live locally. She's relatively low income, just collecting the maximum government entitlements. She hasn't had any home care until now. She's having need for that, but not before. Her balance is a bit off, having some issues with walking now, and is skipping meals or eating a lot of processed things because she's just really finding it hard to do meal prep and housework. So when you actually go and look at her unit, there's a lot of trip hazards. There's no bathroom equipment, no grab bars in the shower. She's got multiple comorbidities. So she's on quite a few medications, has a lot of pill bottles, unsure about how often she's actually adhering to her medication. And because of some of her recent mobility issues and a lack of ability to get there, driving, she's not been going much to her family doctor. She has lost a couple of people in her life recently, so has some grief, and recently tested sort of in the area of mild cognitive impairment. So some of the things that we could do just quickly, I mean, often it's a referral to geriatrics as it's going that way, but that might take a few months, having a pharmacist review, maybe getting her going on a blister pack, like I mentioned. Definitely doing a home care referral. Her balance is off now. She's going to need some help for showering. Having an OT, a home and community care OT, go out to do a fall safety assessment and get an application going so she can get a walker. Meals on Wheels would be an excellent thing to get going for Mrs. C. Maybe a grocery delivery service to help her to get some other healthy things in. Making sure she's connected with DARTs and possibly a community connector to help her get to some appointments. Also, I mean, offering resources for counseling bereavement, if that's something that she was interested in. And I just put at the bottom there, of course, this is near to me. The ideal, I think, is also, again, getting her involved with a multi-component exercise program. So there's lots of them out there. The Live Well series, Jairus Dance is one of those, but they have many programs. The Stay Well at St. Joe's, Goldies to Home. So there are many great programs out there. With the goal really of keeping Mrs. C above the frailty tipping point. So sending her more towards the green robust and away from the red frail going down into dependency. So I know my time is up here for sure. But here's just some key messages. So I'll pass it over back to Alex in case there's any questions. And please feel free to email me if there was any other questions that aren't covered. Thank you.
Thanks so much, Courtney. That was really a wonderful, comprehensive approach to screening and assessing for frailty, and there's things we can do. There's two questions in the last 2 seconds. The app looks great from Adrian. Where does the data go? He's thinking about patient confidentiality.
Okay, thank you. Great question. So it's something, so you're going to download that either on your phone or on an iPad. So it's all de-identified information too. So that's something you could just use as a calculator, but you can de-identify, send that over via email, or we're working on other ways to download that. But if you're a researcher, it can be downloaded as an Excel file too. So the purpose of the tool really is twofold. It can be clinical and it can also be used for research purposes. I don't know if that answers your question, but.
And the second question is there since frailty scale that works better for predicting anything else predicting cognitive function, because this looks at predicting mortality. Actually, the frailty scales do more than just predicting mortality. They predict falls, hospital admissions, and multiple outcomes. So is there another tool for predicting cognitive function?
I mean, I would say, I mean, as Dr. Papiano mentioned, I mean, yeah, I mean, you could use cognitive assessment tools to really do a deeper dive.
Yeah.
So I think if we use, I mean, even talking about the app, it does include cognition, and we do a cognitive screen. So it might highlight an area that you need further testing. And maybe these are the people you're referring to, geriatrics.
Right. So thank you so much, everybody, for joining us for that half an hour. It will be on the RGPC Central website, so you can review it with those who weren't able to attend. Thank you so much again, Courtney, and thank you very much to Emma and Jen, who organized and are our planning committee.
Thank you so much.